Good morning, everybody. Can you hear me in the back? Perfect. All right. As you know, we've been going through the optimization review for quite some time, going back to last February of 2018 when it started. And part of the issue was, of course, we had a transition in government, and then it's the new government wrapping their heads around the actual review itself, let alone the findings of the review. So what I'm going to do today is I'm going to highlight some findings of the review that show how we operate as a hospital. So the examination was to look at how we operate, how we function 5 years post realignment. And then also get us into a position as we move forward to make sure our programs and services and the way we operate and function are consistent as we move towards hopefully one site. And regardless of that, just on an ongoing basis to make sure we're on the right track because of what we did in 2013 and 14. Our issue as a hospital since 2013-14 pretty much has been there's a problem with the funding formula and the way it recognizes our operations. So we've been articulating that and advocating that to the Ministry of Health, and you'll see as I go through this report that there are some conclusions with respect to that have been found as we move forward. So just as you all know, what we do as an organization on an annual basis and even shorter than annual basis is we compare ourselves to our peers, to the peer hospitals program by program. And we look at how we're functioning as compared to them, maybe why are they doing better than us, why are we doing better than them, is there certain ways we capture that data, is there certain things we have in our programs that they don't have and vice versa. So as a part of this review, they did the exact same thing. They looked at ourselves as compared to our peers, and the ministry was the one who selected our peers. I had to black them out because there are other hospitals, and I'm not allowed to share other hospitals' data because I don't want to get a phone call by about 18 to 30 hospitals in the next half hour having them describe that where they finished as compared to everybody else and why am I sharing all of their data. So as a result, this summary is going to pretty much have everything that's in the report, including some quotes. It's just we can't release that data, which is significant because it affects other hospitals that are not in this room and have not consented to it. So the first thing they look at is, okay, if your hospital was operating in every single program in the best quartile, how much could you possibly save theoretically? It's a theoretical number. And there is no hospital, so you know, in this world that is operating at the best quartile as compared to its peers in every single program. It doesn't exist, but it's a theoretical savings. So then you can look at, okay, as compared to your peers, how are they performing with respect to that? So basically it says when they do that snapshot for us, we could arguably save 10.5% if we were working at every single program in the best quartile. What this report indicates already, we are performing better than 14 of the 16 peer hospitals. Already out of the gate. We're at 10.5%, you can see I think it goes all the way to 17, close to 16.8%. The lowest is 8.5% in that whole range. The peers were selected by the ministry, and one could argue about the peers, and we're going to talk about that on the peers that were selected. So another part of this report shows this number is the critical one, the 8.7%, is it shows the percentage of acute tertiary care we provide. So as you know, tertiary care is high-level care, and 8.7% is a significant number because if you look at our peers, there's only one at 10.7%, which is higher. Everybody else is in the 4 to 6% range, or just 7.5%. So when I say as compared to our peers, we have more tertiary work than our peers do on that list. And not only, as you know, tertiary work comes with higher expenses. So one would expect when you're performing this type of work at a higher expense rate, maybe you won't be as efficient when you're comparing yourselves to peers. So what's not included in our peer ranking, so you know, are academic hospitals. One could argue they should be, they're not. So even because they're not, we still perform very well clinically and financially as compared to these peers, which are similarly situated hospitals across the province, but the same size, doing similar programs. But again, on this slide shows that it's not a perfect science, and if anything, we're performing more intense, more costly work than our peers, but still, when we're compared to them, are performing very well. Another way of looking at it is they look at, okay, how many of your programs are performing at the median or best quartile? We have 58% of our programs operating at the best or median quartile as compared to our peers. I was told the highest number they've ever seen is 62%. So again, that means the bulk of our programs are performing very well, which is consistent with where we rank as compared to other hospitals. Historically, how that number has played out since realignment is we started at 13.2%, it increased a bit, it dropped to 9.9, again we're at 10.5, and from my understanding for 18-19 we're probably in the 9 range again. We estimate we should be, I think, around 9.6, somewhere around there. So basically what this slide shows is that we continue to become more and more efficient throughout the years. So we just didn't sit back and not become more efficient, as all of us worked very hard, frontline staff worked very hard to become as efficient as we could be post-realignment. What this compares is it looks at, again, that slide where it says we're at 10.5%, the lowest is 8.5%, the best quartile is 11%, so we're at 10.5%, so basically that concludes that we are already operating at the best quartile corporately as compared to our peers. Another way of looking at it, again, they look at this from different ways, is, okay, out of those indicators or programs, we have the second highest or best at better than median, we have the 7th highest at better than best quartile, and we have the lowest at or above median or lowest at or above 75th percentile. So pretty much we're the best of those who are poor performing. We have the least amount in those areas of poor performing programs. All of our programs are more towards median and 75th percentile. Again, that's why when we compare to our peers, we are performing very well. So they look at, when they come in and they examine, they not only look at, okay, take a big snapshot corporately, how are you performing? How are you performing as compared to your peers? But then they start drilling down. Where are you spending your money? So you might be not spending a lot of money, but are you spending it in the right areas? Could you move money from one area to another area and therefore become more efficient or a better operating hospital? So again, they compared ourselves to our peers, and they indicated that a low rank is an area where you're spending a lot of money in, a low number here. So when it comes to inpatient nursing, direct total nursing, food services, we are spending our money where it should be spent, which is with the patient, frontline care. So these are all these numbers. Ambulatory services, we're not spending a lot of money there, so we're not, quote, say, overspending in that area. And one area they look at, they always talk about, you know, is there some low-hanging fruit? And if we can cut overhead costs, you can shift those monies into frontline care, we're performing one of the best. And that number historically is very low as a percentage of the amount that we're spending, because we're not spending a lot on overhead. So there's not anywhere they conclude we have no where to shift money in order to spend it more in frontline care, because we already are spending our money in frontline care. So then they look at, okay, maybe the population coming to you, is there any uniqueness about the population coming to your doors? And the one thing about our population, which a lot of you know, is that unfortunately, Essex County has one of the most deprived populations across Ontario. Out of 49 counties, we're the 5th worst. And in fact, there was a national survey, Windsor West had 32% of the children under 17 living in poverty, and it's one of the highest in Canada. Windsor itself, 17 and over, is some 20%, which is still one of the highest in Canada. I think the average across Canada is below 15%. So Windsor itself is very high. So basically the population coming into our doors are deprived, and usually that attaches to needing a higher level of healthcare services. So we all know that. That's the population we're seeing coming in every day. A great percentage of them need extra healthcare services. So then what they look at, okay, your overhead's fine, you're spending your money in the right spots, you have a deprived population. Maybe when that population has come into your hospital, are you admitting too many of them? So if you're admitting too many, if you got your admission rates down to where they should be, you could arguably save beds, and therefore you could arguably close beds and have that money available. So are you taking in too many patients? So they did that examination, and what they looked at, sorry, I jumped ahead, is that for the Met site, we had 89% of the patients that should be admitted were admitted, and OLET 92% of expected. So the numbers, if every single patient is kind of like the hospitalized standardized mortality ratio, is patients come into the emergency department, they have a data set. A patient coming in with a particular set of comorbidities, they have a percentage. Should that patient internationally be admitted to a hospital based upon those comorbidities? If you're right on, it's 100. 100% of those patients coming in with that should be admitted, you're admitting 100, you're right on. If that number is above 100, that means you're admitting patients that technically shouldn't be admitted. What this shows is we're at 89% at MET, 92% at OLET, which shows we are not admitting as many patients that technically should be admitted, is we're doing a very good job. And a lot of it has to do also with the community resources. So when they're coming, say, to the emergency department, if there are community resources available, we are diverting them to those community resources rather than admitting them in the hospital. And we're seeing, if all of a sudden your readmission rates were very high, that wouldn't be a good number, but our readmission rates are pretty good. So it's not as if they're ricocheting and coming back either. So as a system, with respect to that, we're doing well. So again, there's no, quote, savings in saying that we're admitting too many patients. And the slide I missed was the patients that are coming in, 13% of them that are coming to the OLET ED don't have access to primary care, 6% at MET. Out of 32 peer ED sites, OLET has the 4th highest percentage of ED patients with no primary care, which again is consistent with the patient population on that previous slide. As they're coming into the emergency department, they don't have primary care, they're using the emergency department as their primary care. So those are the patients we're seeing and we're caring for. This slide is a significant slide, as it compares our patients as compared to every single other patients across the province and the various LHINs. And what it looks at is the multi-morbidity prevalence. So you will see 40% of the patients that come to the Erie-St. Clair LHIN that come to our hospitals, 40% of them have multiple morbidities. And that is, as you can see, the highest in the province. So that means they're coming in with more than one health issue. Coming in, and as a result, as you know, when someone comes in with more than one health issue, they become more complicated because you're dealing with multiple issues, and they can really strain a system in the sense of the expense, if you're looking at it from an expense ratio, but clearly from the types of patients you're seeing. Unfortunately, the way the funding formula works across the province is you have what's called resource intensity weighting. So resource intensity weighting takes into account a patient's comorbidity. Now, on an annual basis, we have approximately 46,000, our last number, resource intensity weighted cases. That takes into account all their comorbidities again. When you look at the cost of taking care of those patients, we're at $4,700 for every single weighted case. That ranks us 15th, which is really good, meaning we are taking care of those patients at a very low system cost, which is again consistent with all the previous data I provided you. It shows we're doing a very good job financially efficiently. Unfortunately, the way the hospitals are funded across the province is using what's called HIGS. And HIGS, what HIGS does is it only looks at the primary diagnosis of a patient. It extracts all the comorbidities. So whatever their primary diagnosis is, that's what weight that patient is given. So instead of 46,000 RIWs, we have 42,000 HIGs. So instead of being one of the lowest out of our peers, we moved to the middle. We dropped 7 spots. So from the lens of the ministry and the lens of funding, we are, quote, less efficient because it doesn't take into account our comorbidities. If you look at that list and you look at where organizations move to, the biggest move is about 2 to 3. Someone went from 6 to 3. We went from 15 to 8. So that's pretty dramatic, again, from a funding point of view. Just the way the funding formula works, it doesn't take into account the types of patients we're seeing. So another lens they look at is, okay, from a surgical lens, is there a way you can move inpatient surgeries to outpatient surgeries? Are you doing too many inpatient surgeries that can be done by outpatient? And if you are, as we know, that's a way of, quote, saving money. That's a way of reducing someone being admitted, of course, to a bed, and et cetera, et cetera, et cetera. So they examined all of that. And they found if we were operating at the best quartile, we would save between the 2 campuses on an annual basis 2.9 beds. So if we can get those 2.9 beds in the same building on the same floor, maybe we could save, a half of an FTE. So there's no savings. So they determined there's nothing. The cases you're doing as inpatient surgery are appropriate, and there's very little shift to outpatient, other than what we continually do is you continually look at shifting, and we're gonna, over the next 10 years, just like for the last 10 years, is procedures that were done inpatient 10 years ago are now outpatient. That trend's gonna continue and not stop, and we're gonna be part of that trend. So basically there's no, quote, savings there. So then they look at conservable beds. And I can tell you historically, this used to be a big issue for us, where it basically says, okay, so we looked at the patients you're admitting from the emergency department, should they be admitted or not. They're saying you're doing a really good job there. Once they get into the building, are you doing the surgery properly? All right, they say you're doing that properly. The third thing is, once they're in a bed, what's their length of stay look like? Are they staying longer than they should be? And the answer to that question is no, bless you, is we have the lowest conservable medicine bed days as compared to our peers, and the 6th lowest as compared to our peers for surgery. So there's, quote, no savings. We're doing a really good job, as you folks know, with respect to our lengths of stay. We focus on that moment of admission all the way through discharge. We do a very good job on discharging patients appropriately and really focusing on our lengths of stay so we don't have conservable beds. I can tell you in the past, it used to be always the issue is you'd go to the government, you'd say, oh, we gotta have this funding, and they say, well, you have 60 conservable beds. If you dealt with that, you'd find all this savings. And if you hear this thing about hallway medicine, one of the issues that probably some of hospitals need to look at is conservable beds, because it could really help with eliminating or reducing, quote, hallway medicine, is if you look at your lengths of stay and make sure your lengths of stay, actual versus expected, is right on. So you folks do a great job with respect to that. This is kind of the kicker slide. This shows from the ministry's lens since realignment how we've been funded. And from a ministry point of view, if you recall, we get funded for 15-16 based upon how we did 2 years previous in 13-14. So we get funded 18-19, we got funded on how we did here. There's a 2-year lag when they start collecting data and moving it forward. So basically what this slide shows is our actual service in 13-14 was 35,000 cases from a ministry lens. And that was, remember, we took over responsibility for Olet midway through, that's why that number is a little lower. That's what we were actually doing. The ministry, the way they fund us, is based upon what we're expected to be doing. And they expected us to do 23,000 cases. So we were funded on 23, but we were doing 35. It got worse here because we had a full year. We were doing 48, we were funded on 23, and it started to catch up, and that's why this fiscal year we got a funding increase because it was based upon that. Our actual met our expected, and that's why they give us more money for this fiscal year. So we've had discussions with the ministry, as they said, now that the system's kind of caught up to you, and I got Dan Wilson here as chair of the board. I should have described that. Dan's been by my side through this, and I get paid, he doesn't. He's been there and he's been part of all these discussions. As they said at one meeting we had back a couple months ago at the start of the new year, they said, well, things should look really good for you because you've caught up, the system's caught up to your actual performance. And we said, yeah, that'd be great, but it sounds like you guys are going to change the funding formula. So we're going to, who knows where that's going to shake out. So unfortunately, what this slide again does indicate is that there was a problem, and this is what we've been articulating for since realignment, is we've been saying our funding is not accurate, and as a result, it has to be corrected. So based upon all of that, the ministry, the report does recommend that for this year, we get $8.2 million one time in this actually past year by March 31st of 2019. We don't have that formally yet. We've been verbally told it's there, and there's a budget happening next week, so we'll see if once that happens, the actual documentation will be released. But what the report then recommends is that we should be getting $16.4 million over the next 5 years to our base. And that is in addition to an assumed 1% increase, which is about $4 million a year. So when you look at, for the next 5 years, we're to get the 16.4 plus $4 million a year, so that's another 20. So technically, it's $36 million a minimum we need. That's in the report that says we're entitled to. And then it says for the debt we've accumulated over the last 4 or 5 years, we get an additional $25 million at $5 million increments every year. So when you do the math, it's a rather substantial number. It's north of $60 million. So what they do say, though, of course, is that hospitals need to continue. We're no different than everyone else in the province. We need to continue to become more and more efficient. So unfortunately, what it does require us to do is find some efficiencies. So when we looked at all the programs that were performing very well as compared to our peers, there were some areas that weren't, but they were specific investments we made. So we met with the union executive, some of them, because it was kind of late. And the reason it was late, just so you know, the reason this is late breaking is this kind of all came together literally late afternoon, and we were said you can go and make the announcement, so we made it. But we've been working on this nonstop for quite some time. It's into months, if not years now, pretty much on a daily basis. So in any event, we met with some of the union executive this morning, and there'll be clearly more details. The areas, there are going to be no areas clinically, like clinical operations will not be negatively impacted. Unfortunately, what's going to happen is we have non-clinical investments and staff that are going to be impacted. So we're going to have some housekeeping primarily, food and nutrition primarily, and we're working with our IBW folks on some clerical staff issues, mostly transcription, but there's a bigger plan with respect to that we're working with the IBW bargaining unit on. And some of these changes have already taken place. Again, more details will start following, but some of them have already taken place with respect to non-replacements as people were leaving. We're going to do our best, clearly as we always do, not to have any type of we'll do it by attrition and retirements as best as we can and work with everybody. What we really focused on, and the ministry wanted us to focus on, and that's what the report looked at, is if there is any possibility for savings, is to look at non-clinical areas so you're not affecting clinical services. So that's what we tried to do, and we did 99% of it. We did our best in getting there. However, that doesn't lessen the impact of this because, again, we put our specific investments into those areas because of the age of our facilities, because of the fact we have 2 facilities, because of the fact we are looking at issues like patient flow, and we look at HAIs, et cetera. So we'll have to keep working on that and move our way through it. But again, we're treated no differently than any other hospital in the province. With respect to that, when we make those changes, not only are we going to be one of the most efficient hospitals as compared to our peers, but the estimates are we are going to become the most efficient hospital in the province of Ontario. In my opinion, I don't think that's the goal of this exercise, and it shouldn't be, and that's why there's been some significant discussions, but we're at the point we're at, and for the sake of the system and for the sake of the hospital, for us to get access to $60 million in funding, we got to continue to do that, which we've always done, and we're going to continue as we go down this path to become as efficient as we can. And I can tell you, they're generally, Dan's here, very impressed with the way we function, the way we operate, from the board to the frontline staff, from the frontline staff all the way up. Very impressed with the organization as compared to others. And I'll just kind of highlight some of the quotes you'll see in a media release. What we did with the media release is it focuses on the purpose of the review, that we had appropriate controls in place, and that we're getting ready for the new hospital. It does highlight, you'll see once you eventually get this press release, which should be very shortly, anything in bold is taken directly from the report. So again, we focus on the patients we serve and the deprivation index. Clinical efficiency, financial efficiency. It says we are more efficient than most of our peers. We have less opportunity for savings. It demonstrates the organization is highly clinically efficient, and it notes we have some of the highest intensity patients as its peers and has achieved low admission rates of its peer group. From a board perspective, it talks about it's a skilled board, successful in recruiting and meeting our vision. The board structure, financial management oversight is positive, and the board is operating with some small exceptions at best practice, which is very positive. From a management point of view, we have appropriate budgeting process in place. A lot of you already know that because you have to struggle with that, especially when we don't have any money. It focuses on our facilities, the age of our facilities, and how it's negatively impacting us. And it highlights our lovely power plant and how that's being held together by our great facilities team. It talks about our community relationships. They interviewed 150 people in our community about us. And they said very positive things about our organization. It talks about, and this is where it says, we're no different than any other hospital, is we're going to be challenged with inflationary pressures every year, and we must manage under the current funding system, and we're no different, and we must continue to do that, just like every other hospital has to. And it talks about the moving forward, we have to find approximately $7.3 million in cost savings as well in those particular areas, and that's the plan we're unfolding today. So all I can tell you from a, I said this to the union executive, I hate to use this phrase, but it's true, good news, bad news. Good news is this report affirms what we've known, is that you folks do a great job, both financially and clinically. We have a very acutely ill population that comes to our doors. We take care of them very well. They are not readmitted, meaning that means we're taking care of them very well at first instance, and our readmission rates are low. So no matter, if you didn't know this, no matter where they go across the province, if they left here and went somewhere else, it identifies they were here, we get charged with the readmission rate. So they don't have to come back to the same spot to get charged for the readmission rate, so they track them. So basically that means our patients are being taken care of very well at the first instance. Again, we worked very hard. There was a lot of people working very hard even in our community to advocate for us, and the ministry has responded positively, again saying they've accepted the report, it's there, it has valid reasoning, and they're going to work with us moving forward with respect to the findings of the report and with respect to the funding that's in the report. At the same time, they're going to expect us to continue to operate the way we've been operating. In the past, you might say, well, why don't they just cut us a check for $60 million? They've done that to other hospitals in the past. And the next year, then they announce a $50 million operating deficit. So they've been burned once, they're not going to do it again. So they're like, we're going to pay you over a period of time on the condition you continue to operate the way you've been operating, and everything will be fine. So if these numbers come through the way this is all laid out this upcoming year, we should have a balanced budget we're projecting as we move forward. So those will be the changes, and again, there are some non-union changes as well, even though it doesn't mention overhead, but a lot of those have already taken place or are about to take place, and people are aware. So okay, so again, there'll be more. This is videotaped, so the staff aren't here can watch it and see it, as well as we'll be issuing this press release will be issued as well very shortly, and it has a lot of the details in it that I just talked about. So I know there's a lot of people in the room. If there's any questions, I'll take them. I'll start at Met. I know it's an impossible spot. If you know what, I forget I won't ask questions, put you in a tough spot. So just send me an email if you got a question, because again, if you're thinking of something, that means someone else is thinking the same question. So send me an email, and then we'll maybe do a Q&A, and we'll run it. But again, all this report emphasizes is you're doing an amazing job. You really are. Rob Devitt, who came in, was at a couple, I can tell you when he came in, he had a different attitude, but he clearly admitted when we were before the ministry in early January, he had a couple preconceived notions that he was incorrect about. Number one preconceived was he was going to come in, find the savings, and walk away. He said, it doesn't exist. It's very little. It's minimal. They need the funding. There's been a funding problem. So he admitted that. The next thing we talked about early on was this realignment was the most complex realignment in the history of the province. That's in the report. The quote is there. And one of the things he said, I don't want to talk about that. Look to the future. Stop talking about that. That's in the past. He said that's a mistake he made too. Is he said that's very important because it was very difficult and it does impact moving forward. And the third thing he said, what's holding us back, and we're spending a considerable amount of money on it, is our capital infrastructure is just, it really is tough, and you guys know that. And that's what we've been trying to say, is we've got to keep moving forward with respect to that, because we're just throwing money away on the existing sites on a daily basis. So again, I'll let, if you have any questions, send them to me, and I will definitely email back and respond, and also on a confidential basis put together a Q&A, because again, if you're thinking of questions, others in the room and outside of the room are thinking of the same ones. Okay, so thank you, everybody. Take care. Thanks a lot.